I want to welcome everyone to the Livewell Kalkaska Substance Free Coalition's Coffee with the Coalition Forum. This is an open and informal discussion about substance use disorders and related topics and concerns within Kalkaska community and Northern Michigan. Today's discussion is on methamphetamines and other stimulants. So before we introduce our speakers, let's introduce the rest of you. Linda? You're muted.
I just muted myself instead of unmuted. Yes, I'm Linda Solom. I am a prevention specialist with Up North Prevention, which is an initiative of Catholic Human Services. And I work with Suzanne, and but I'm in Grand Traverse County. And was there anything else you needed to know, or?
That's it, just introduce yourself.
Okay, thanks.
All right, Mandy?
I'm Mandy. My husband, Adam, and I own Life's Word Clinic. We're a behavioral health clinic in Kalkaska, and we also do MAT. So,
all right, thanks. Kim?
Hi, my name is Kim. I'm a peer recovery coach, and I work with Harm Reduction Michigan.
All right, thanks. And so our speakers today, we're going to welcome Dr. Rob McMorrow. He's a specialist in addiction medicine at Mid-Michigan Health, and assisting him is Tim Hudson. He's a behavioral health consultant for Region 2 and 3 with the Michigan Opioid Collaborative. All right, so you're able to share if you need to share any screens, and go ahead, take it away.
Great, thank you so much. We enjoy being here. Tim, I don't know if you want to jump in beforehand, but I think, I don't know if you'd introduce yourself, or I don't know if the whole team knows you.
Yeah, it looks like we got some new faces on, some folks that maybe I haven't met yet. But so I cover the Northern Michigan region, the 21 counties for the Michigan Opioid Collaborative. I work with Dr. McMorrow. So we're a grant-funded program with University of Michigan. Our goal is to increase awareness about substance use disorders and medication-assisted treatment, making sure that we have that available throughout the state. For me, I'm focused primarily on the 21 northern counties. Certainly some room to grow here in these counties and bringing awareness and education to folks. And we also do things like presentations to reduce stigma, benefits of the medication. We recently did a presentation last week on fentanyl, as obviously we've seen fentanyl just continue to really be a major problem in the state. So those are some things that we work on at the Michigan Opioid Collaborative.
Great, thanks, Tim. So my name is Robert McMorrow. I'm going to share my screen here. We're just going to go through a quick presentation of kind of psychostimulants.
We did a presentation last week.
That's put me down.
Hello?
Yeah, no, I was trying to put this on Facebook and.
Oh, all right. So we're good to go here?
Yeah, we're good to go.
Okay, great. I don't know if you guys can, let me know if you could see this. Can you see this?
No, not yet. I should be able to share it though. There we go.
No, it's not opening. Can you see that now?
Yep.
Good to go?
Yes.
All right. Sorry about that.
Thanks. No, you're fine.
So yeah, just to kind of go through this psychostimulants. This is always kind of a fun talk. Feel free to stop me if you guys have any questions or anything like that. It's kind of an informal talk. And so just a little background. I did a emergency medicine fellowship and then emergency medicine residency. I practiced as an emergency medicine physician, and then I went back and did a fellowship in addiction medicine. And I'm the current director of addiction medicine at Mid-Michigan Community Health Services. I also work with the Michigan Opioid Collaborative, and Tim is a consulting physician. So we do try to do a lot of education up here, and just kind of whatever the community needs, and do a lot of consulting for a lot of medical questions I get too. So feel free to stop me there. I'm also the stimulant grant director for the NMORC. So just a couple of objectives when we're going through these. First, we want to be able to define a psychostimulant, define stimulant use disorder. We want to gain some knowledge on history of psychostimulants and the current epidemic. We want to identify the most effective strategies and therapies to treat those with stimulant use disorder. And then also we want to promote continued discussion and collaboration aimed at potential solutions for stimulant use disorder. So we'll just go through a background a little bit. So a lot of stimulants you'll hear, kind of a broad category. I broke it down into kind of plant-derived stimulants. We see these pretty common in a lot of areas of the world. People are familiar with cocaine or the cocoa plant. Ephedra, we'll see that in North America and East Asia. This is a plant that contains ephedrine. Cat or khat, this contains cathinone, and you'll see this in East Africa and Arabia. You can see this guy right here with this kind of big cheek of it. And then also there's some reports of kratom. We're seeing a lot of kratom up here, and based on what the dosage is, it does, we're seeing exert a stimulant effect, and we can go through that more as well. So synthetic stimulants, just so everybody kind of gets a background, these are available by prescription. We, base the fundamental amphetamine we hear with Adderall, which is used for ADHD. Lisdexamfetamine, that's the molecule for Vyvanse, which is also used for ADHD. Methamphetamine, that's actually in prescription form with Adipex, ADHD, and weight control. Methylphenidate, which is a stimulant. You'll hear Ritalin, Focalin, Concerta. Modafinil or Provigil. This is used for narcolepsy or shift work disorder. Phentermine or Adipex for weight control. And then over-the-counter stimulants too that classify. You see caffeine for alertness, ephedrine for a decongestant, Sudafed as well. And again, these can all oral stimulants, both prescribed and over-the-counter, are widely used in the United States and even in the world for work, military. They're used for alertness, anti-fatigue, sleep suppressing, performance enhancing properties. All these stimulants do have a potential for misuse and addiction, and these kind of just vary only in their potency. We're going to focus on cocaine, amphetamine, and methamphetamine, which have the highest addiction potential, and we'll see a couple reasons why. And then the greater the addiction liability, because we find that methamphetamine and cocaine are pretty consistently or often used IV or smoked. And this kind of allows for that, faster rate of delivery. So it reinforces the effect, and you can kind of get to that addiction potential faster. We see this used in a variety of patterns. We see binge uses. Patients will tell me, hey, I go on a binge for 2 weeks, and then I kind of just stop. We see frequent use. A lot of times people will use frequently over 6 months to a year, and then they'll come in when they're out of money. And then also I hear people will just maintain. They use really slow doses without any escalations. They use just a small amount in the morning or whenever, just to kind of maintain their kind of how they're feeling. So stimulant use disorder, by definition, this has evolved over the past couple of years. In the DSM-4 criteria, it came into abuse, we used to call that, versus dependence. And now we define it, as a stimulant use disorder, greater than 2 or equal criteria. And again, we recognize cravings. Greater than 5 is severe, 4 to 5 is moderate, and 2 to 3 is mild. So this is kind of the fundamental definition that you'll see if somebody develops a stimulant use disorder: mild versus moderate versus severe. That's where all these terms come from. And basically how many check marks or how many criterion they comply with depends on what their severity is. So first thing we'll go into is cocaine. And again, feel free to stop me if you have any questions. Cocaine, how does cocaine work? It's kind of unique. It blocks this voltage gated sodium channel. So if you can see my arrow right here into this cleft, it blocks norepinephrine reuptake. So it causes this vasoconstriction. And remember, people realize that they think cocaine and dopamine, but it also has other effects on serotonin and norepinephrine. And so it has some pretty, and it works on the synaptic cleft right here. So you could see these dopamine particles kind of hang out there longer. And that's the main kind of contributor of it. In the modern history of cocaine, it was first isolated in the mid 1800s. It was actually used to treat morphine addiction in 1879, which was pretty interesting. Coca-Cola did have it in their cocoa leaf extract from, and in 1903, it was removed from formula for Coke products. It was sold over the counter by Merck, and it was heavily endorsed by Sigmund Freud, the renowned psychiatrist or psychologist. Use declined in the 20s and 30s with regulation and introduction of amphetamine. And then we saw this big resurgence in the 70s and 80s. In the 70s with the powder, and then the 80s in the inner city, when they developed the crack cocaine. So how is cocaine produced? You'll see it in, this initial paste is pulled from the leaves, and it's stomped on with this sulfuric acid. The leaves are chopped, mixed with lime and kerosene, and then it's ground into this paste, which is about 40 to 80% of cocaine. I won't get in too deep with it, but the hydrochloric acid is added to make a purified water-soluble salt, and before it's exported, and that's where you see this powdered cocaine into bricks. You also hear other terms like free base and crack, and that's just basically by adding a base, free base, like ammonia, and then they'll extract it with ether. And then crack is made by mixing baking soda and heating, and then you'll avoid that kind of ether contaminant as well. Adulterants, this is kind of interesting. Cocaine purity averages about 40%. And again, this is a big kind of problem. One estimate on the research I read is that about 70% of street cocaine is contaminated with this I can't ever say it, levamisole and this dexamisole. This is basically a horse dewormer and potent modulator that you'll see in veterinarian offices. I don't even think it's legal anymore, but it's thought to prolong cocaine's effect. And this is the vasculitis that you can get with it. It kind of constricts, and they can lose ears and noses. The mechanism behind it is not well understood. Other adulterants. And again, when I say adulterants versus bulking agents are sugar, talc, and cornstarch. Adulterants and these are pharmacological active substances. So you'll see caffeine, you'll see diltiazem, which is a common blood pressure pill, hydroxyzine, which is used for anxiety. And again, 50 to 90% of users binge with alcohol. And also you have to be careful when you're talking with your patients too, because this really puts you in increased risk for developing toxic liver damage. You'll see with cocoethylene, which is a very toxic liver metabolite than you get when you combine them. Routes to the brain, topical within 5 minutes, intranasal, you'll get about 5 minutes, then it'll peak around 15 to 20. It'll last about 60 to 90 minutes. So you see, as you go down the line, IV versus inhalation. Inhalation is the fastest, 3 to 5 seconds. You feel the effect. It also has the downside. It only lasts and peaks, within 1 to 3 minutes or 5 minutes. And this is the metabolite that you get, the major metabolite you get in urine for cocaine. Benzoylecgonine is kind of how you pronounce that. I've had to do that 10 times. This is formed by the liver and excreted in the urine. The detection window is around 4 days for urine. I've seen it anecdotally in, heavier use longer. I've seen it up to 7 days or 10 days. Blood, we don't usually do blood tests, but that's around 2 days. And then saliva, 2 days. Hair is 3 months. The false positives is very rare in cocaine. So usually a positive test on the cup, indicates cocaine. Any questions so far? All right. So we can see with overdose, it's kind of trending upward. And this is throughout kind of the whole country here. I think the last estimate, I think it was in 2019, there was about 1.5 million active people using cocaine or qualify for a substance or a cocaine use disorder. And we can see this kind of yellow line. This is kind of interesting too, that the overdose from cocaine has gone up, but it also has gone up pretty exponentially combined with synthetic opioids. And this is other than methadone. So you're most likely seeing fentanyl mixed with cocaine. And then you'll see this line, it's actually pretty steady, is cocaine without any other opioid. So this major problem with the speedballing and mixing the two. What are the acute effects of cocaine? People will say they get euphoria, increased energy and libido, impulsivity, increased alertness. When you get the higher doses and you escalate the frequency, people will get insomnia, anxiety, confusion, paranoia, panic attacks, hyperflexia, tremor, they're sweating, tachycardic. And then, you can get overdoses, convulsions, hemorrhage, or infarct. And remember, it's a different overdose, your stimulants, than your opioids. You're getting strokes, you're having heart attacks, you're having cardiac arrhythmias. You're getting rhabdomyolysis, which is dehydration, which is secondary to extensive kidney failure. And remember, in pregnancy as well, with placental abruption. So now we'll just kind of dive into methamphetamine. And what is methamphetamine? This is kind of a white powder pill. It's easily dissolves in water, alcohol. People will call it rocks or glass. Sometimes it can look like a shiny blue white rock. It can be swallowed, snorted, smoked, or injected. It can also used rectally as well. Street names include speed, crank, chalk. I've heard that. Trash, dunk, Scooby snacks, rocket fuel. What is the prevalence of methamphetamine? In 2015 to 2018, approximately 1.6 million adults on average use methamphetamine each year. Again, that's similar to the last one I saw in 2018 with cocaine use disorder, which was about 1.5. So it is a tremendous amount of people. Nearly 25% of those reported injecting methamphetamine. And approximately 50% of the person using methamphetamine in the past year met diagnostic criteria for methamphetamine use disorder. And again, fewer than one third received treatment for that. What is meth made from? It is a combination. You have the shake and bake that can be made, kind of in the lab out in rural America. Or a lot of it is coming from, the border and shipped in from Mexico. But it's using these toxic chemicals. You'll see acetone in nail polish removal, lithium used in batteries, toluene used in brake fluid, hydrochloric acid used to make acid, pseudoephedrine, you'll see that in cold medicine, red phosphorus, you'll see matchboxes, and sodium hydroxide, which is basically lye. So a lot of toxic chemicals in there. We're also seeing a lot of counterfeit pills. These started to really appear in 2019 and 2020. And we're seeing these come up from Mexico. These are distributed high purity and high potency across the Southwest border. We see the domestic production, the shake and bake shops really decline in the United States because there's so much of a push through the Southwest border. And it's just this high potency, low cost counterfeit pills. So a lot of my patients will say, oh, I'm taking, Adderall I got off the street, or, whatever stimulant it is. And it's definitely not that. How does meth work? It's a little different than cocaine. It kind of has a four-prong approach. So if you can look here, this is kind of your normal synaptic vesicle in your synapse and how your neurons work. But then you see this methamphetamine induced changes. So basically it hooks onto this inhibitor right here. So it inhibits this VMAT, this vesicular monoamine transporter. So more dopamine is kind of dumped out into this in the end of the axon right here. And that also kind of hooks on to the reuptake, and it opens up these channels here. So the synapse, you get this big surge of dopamine, norepinephrine, and serotonin. And this causes reverse transport into the synapse, and it displaces these from the synaptic vesicles. So basically you have all this competitive inhibition, and you have all this uptake of these monoamine neurotransmitters. And this can last for a very long time. And this is why meth is so difficult. You get this huge drive of dopamine concentration. You might see this with, sex or eating chocolate cake. You get this kind of little blip. And again, this dotted line is kind of your baseline of dopamine. Throughout the day, you might not be waking up, you drink your coffee, or you hear some good news, you might get a little blip in the brain. But this tremendous, huge shift, smoking or doing IV methamphetamine, really jacks that dopamine levels up in the nucleus accumbens and hijacks the survival system. So your brain just kind of realizes it over time that this is a really, good thing to them. To the brain, because it increases the dopamine. So the brain kind of learns to like this. And then once it gets into that survival system, it goes ahead of food, sex, water. Stage 1, you get this 5 to 10 minute rush. Stage 2, you get this 4 to 14 hour high that you hear. And then stage 3 is usually the crash about 24 hours to 48 hours after, that you'll hear about. Health effects of methamphetamine. You have increased wakefulness and physical activity. You'll get decreased appetite. A lot of patients will start to lose weight. Increased breathing, heart rate, blood pressure, temperature, irregular heartbeat. And long term, once you get 3 to 6 months or even shorter out, people will start to get anxiety, confusion, insomnia, psychiatric mood problems, violent behavior, paranoid, hallucinations. And again, this is all from that huge monoamine increase in this dopamine flood. Delusions, weight loss. People won't sleep for a week. Other health-related issues, pregnancy. You'll get premature delivery, placental abruption, low birth weight, lethargy, heart and brain problems. It is considered neurotoxic in pregnancy. And again, in combination alcohol, another issue is people will kind of not notice the effects of alcohol and drink more. So this can actually increase the overdose of alcohol as well. And we're seeing the same trend in overdose that we saw with the cocaine use disorder into the methamphetamine use disorder. And again, this yellow line, you can see it's almost non-existent. You see this rise in 2016 when fentanyl kind of took over, and 17, and then it just kind of blows up in 2020. This psychostimulant overdose in combination with synthetic opioids, other than methadone, which is again what you're seeing with fentanyl. So what are the overdose signs of methamphetamine? Similar to cocaine, you see this hot flush skin, severe headaches, chest pain, unsteady walking, difficulty breathing. A lot of people will present with psychiatric symptoms, hallucinating, picking, confusion, tremors, a lot of spasmings or jerky movements. So then we get into kind of withdrawal symptoms. With the methamphetamine, it's a little longer than the cocaine. About day 4 to 7, people will get really depressed, exhausted, hallucinate, panic. They'll have huge cravings, irritability. A lot of times people will say, I slept for about 4 days straight. And again, this kind of goes from week 1 into week 2. By week 3, they're still, they're starting to get their mood back, at least anecdotally, what patients have told me. The depression and fatigue is still there, but by week 4, they start to feel a little bit better. So you got to remember, this takes time, especially based on, how your metabolism works, how your genetics works, how much frequency, how much you're using, the amount you're using. So these all take into account. So a lot of times by week 4 or 5, people will say, man, my mood is really improving. I feel better. I'm I'm clear headed, but it takes time. So we have to support them and really be patient. And I'm sure most of y'all have heard of post-acute withdrawal syndrome or PAWS. This can be 3 to 6 months of, mood swings, cravings, depressions, that kind of behavior. So a lot of people ask, what are the treatment options for stimulant use disorder? Unfortunately, from a medical, where my kind of main focus is, a lot of times is medication, right? There is no FDA approved medications for stimulant use disorder, or methamphetamine use disorder, or cocaine use disorder. There is some literature that supports maybe people with underlying or untreated ADHD will benefit from a stimulant. If they do that, maybe they're treated incorrectly, and maybe that's why they developed a stimulant use disorder. The literature is not 100% clear on that. There is a recent study with Wellbutrin and Vivitrol. The data wasn't great as far as number needed to treat. I think the number needed to treat for success was about 10 or 12 patients. There's a lot of behavioral therapy that has been proven, out of the medication, and there's other medication off label too, but we won't go heavily into that. But CBT therapy. So a lot of times patients will come in and we might use some off-label medication, but we'll get them in counseling, encourage CBT therapy. We're trying to set up contingency management. Basically, what this does is it's motivational incentives for positive reinforcement. We provide something of monetary value to patients to incentivize them not to use drugs. We do know that the larger rewards work better. And frequent immediate rewards also work better. There is some political and funding barriers to this. There is something called the matrix model, which is more towards CBT and behavioral, consistent behavioral and counseling support that way, or IOP. Some people we'll try to get them into an intensive outpatient program with counseling and things like that. And then always don't forget about the 12-step. We don't know what a lot of our patients don't know is even trying them or, engaging them or introducing them to the 12 steps. There's a lot of help that can be done with that if they gravitate towards that as well. So just a couple more slides on other stimulants. Caffeine. This was I'm sure a lot of us do drink caffeine. It is considered a stimulant. This was domesticated in Ethiopia greater than 800 years ago. It's used regularly by 90% of Americans at an average of 200 milligrams a day. Intoxication, we can, believe it or not, I have seen people get intoxicated and overdo caffeine, similar to other stimulants. And we do get withdrawals from it: headaches, fatigue, difficulty concentrating, dysphoric mood lasting for a couple days. Ephedra, again, this contains ephedrine and pseudoephedrine. This is a herb used for thousands of years in Chinese medicine. So I just want to introduce that to you. It's basically this low evergreen shrub with small scaly leaves. You can see it in here. And in 2004, the U.S. banned the sale of dietary supplements containing ephedrine alkaloids. So I don't think you should be able, well, you probably can, but shouldn't be able to get these online as well. What else? Kratom. This is kind of interesting lately, and we're seeing a lot of topics about this. What is kratom? It's this speciosa, this basically this tropical evergreen tree in Southeast Asia in the coffee family. And it is traditional folk medicine to treat a number of conditions: musculoskeletal pain, anxiety, and depression. You'll see it in Southeast Asia. If you even Google it, they can chew it, smoke it, pound it into powder, and it can be obtained from the internet and, quote, legal high shops. It has been marketed as a cheaper alternative to opioid replacement therapy without a need for prescription. And the reason I put it in the stimulant use disorder, and again, this is, all the alkaloids and I think it's up to 30 alkaloids that have been tested and found in this kratom. But these are the two specific for the opioid-like properties. But we're finding, we're reading about a stimulant use effect at lower doses, less than 5 grams. So that, just to keep on your radar, and always ask your patients kind of, about kratom. A lot of them don't, consider it a drug or a drug of abuse. So sometimes if you don't ask them about it, they'll kind of forget to mention it. So I've made that kind of mistake. And then also cathinone, you'll see this in the cat tree. This is in Ethiopia or Yemen. I've also seen this in the military with a couple patients. They kind of cheek it, and it's chewed ubiquitously in Yemen as a social lubricant, and it's used to embolden and desensitize child soldiers as well. So that's just kind of a broad overview of different stimulants that you might come into or read about. But most of the time is cocaine and methamphetamine. I put this in a last slide as, again, not to forget to use or provide our patients with Narcan. A lot of times if they're just stimulant use disorder, we forget to give this. But we also have to remember that there is such an overlap, and we're seeing, like those two slides, that with the cocaine, with the methamphetamine, we're seeing a ton of fentanyl mixed in, whether it's adulterants, whether it's cross-contamination, whether it's more high for your buy. So please remember to, even if your patients think they're doing methamphetamine or cocaine, to provide Narcan and to do that harm reduction. So that's just kind of wrapping up. That's a quick talk on stimulants, and, I open it up for any questions.
Thanks. Anybody have any questions? I'm sure you do.
There's a comment in the chat from Kim that she has clients that use kratom to help with withdrawals from Suboxone.
Yeah, that's pretty. I don't know if you've run into it, Tim, but that's pretty common. Again, with that, I'll go back to kind of that slide. So these two, this hydroxymitragynine, which is about 2% of kratom by weight, and it also has this opioid agonist, which is 13 times more potent than morphine. So you have these two opioid agonists in kratom that will latch onto those opioid receptors, and that's why you won't get, that kind of withdrawal. The problem is we don't have really much studies on it, and we don't know kind of long-term the effects of it. We do know that, people can develop a tolerance, an addiction potential, a kratom use disorder, which is analogous to an opioid use disorder with the kratom. So we really got to be careful with that. And also another thing I tell my patients, all right, so you're getting kratom, they get them from, the shop next door, they get them from online. We don't know how they're making it, how they're mixing it. It's not like they're going to the local, FDA approved pharmacy to get this stuff. So a lot of it can be mixed. And so we really got to be careful that way as well.
I've heard that if you overuse it, you can get hallucinations.
Mm-hmm. Yep. Yeah, absolutely. I've had quite a few patients that developed a kratom use disorder similar to, to get off their opioids. And now, they developed a tolerance. They started with, a small amount, and they're taking, 20 grams, 25 grams a day, just huge amounts. And it's, and it's lasting less and less and less. And the withdrawal symptoms are brutal. So it's just, I really, really talk to my patients about it and let them know that, hey, this is not approved for this. You don't know what you're getting, and you can really get into some serious trouble with it. So
we really don't have any medical treatment for people who are on methamphetamines at this point.
No, like I said, that study with the Vivitrol combined with the Wellbutrin, it's limited. It doesn't have a great that number needed to treat. I've used some off-label medications, with the Wellbutrin if they have a smoking use disorder as well. But yeah, it's tough. We don't have, great medical FDA approved medications for this yet. So
Yeah, it's hard to get treatment as well because it's when they're on this or coming down off of this and they're having the hallucinations or they're not quite, doing
Right.
the right things. It's like we
Right.
have nowhere to put them.
Yeah, and I've heard from patients say, "Oh, I tried to get into a stabilization. I don't even call it detox anymore, right? So stabilization or a residential program. Oh, I don't qualify that because I'm only taking meth." It's
Right.
like, what? I mean, that's beyond my comprehension. So,
Right.
it's pretty unfortunate. And then, we do know the data does show that really heavy duty behavioral CBT, IOP, intensive outpatient program, with the behavioral side of things helps, but our nearest IOP to my clinic is an hour away. I mean, how many patients of mine can get to, somewhere 2 days a week, let alone get to the office, which is 5 minutes away. So you're really handcuffed. But we do know that, contingency management does work with the data. The problem with that is we're having some problem with the state because the data does show you need a high monetary value and you need it, pretty to do it. And then also once you stop that, the contingency management, the studies show that people relapse pretty fast. So it's tough, but we're trying our best. We're trying to develop that through the state and through our clinic, and positive reinforcement. We're trying to combine anything we can. We're trying off-label medications sometimes. Engaging with counseling. Supportive socially. We introduce the 12 steps. We bring them in frequently. We do anything we can to kind of motivate our patients to, try to stabilize. And again, what is success? A lot of times we define success if, say, somebody, just for example, is doing IV methamphetamine, 0.5 gram a day for 6 months. And a year later, they do it occasionally, smoke it once a month. I mean, that's huge, right? So we gain that frequency, we decrease the frequency, we try to, decrease the frequency, decrease the amount, and slowly over time, sometimes that's the best we can hope for. So.
Right. Do you see, now I've heard this, and I don't know if you've seen it, with the new methamphetamines coming in, they use a different chemical rather than the pseudoephedrine. And it's creating a little more violence, more hallucinations. It seems like they're in the, I don't know, it seems to last longer, where used to in a couple of weeks they were feeling better, but now it seems more like months. And I've seen this out of personal experience. Have you seen anything similar?
I'm not really sure the specific chemical. I know that, these reports of the new purity of meth coming from the southwest border with the counterfeit pills and everything is just, saturating the U.S. market. So I don't know if it's something different, some different precursor that they're putting in to mix it. And that could be definitely the case, because it's
I don't know.
impossible to say.
I'm not sure where I heard it. Was some sort of a talk that I was on where they had said, might have been a DEA one, where they had talked about they're not using pseudoephedrine like the shake and bake does. They're using a whole different chemical.
Yeah, I think that's the what's coming out of Mexico with those precursors and everything.
And I think that's what a lot of the people now are doing. They're buying it that way because it's cheaper and you don't get in as much trouble from using it as you do making it. So
yeah. Mm-hmm.
But it seems like it's really changing people more long term. I've seen people, I don't know. What do you think, Kim? Definitely a difference than a few years ago.
It's definitely crazy. Just the amount of it that goes around. I mean, it's readily accessible. People know where to get it pretty offhand. The people that I talk to. Yeah, it's pretty crazy. We were talking about kratom earlier, and actually I was at a barbecue yesterday, and a man that was there was talking about his addiction to kratom that he had, and he was talking about how after a while he had to have it, and it got to the point where he said it's really disgusting, and that he was just pounding sludge basically just to make him feel okay. He was like telling me about that yesterday.
Yeah, no, I see that all the time. People start to, with a couple pills here and there, and before you know it, every 2 or 3 hours, they're just crushing, a higher and higher dose and over months, and it just becomes unbearable. So.
He said it was quite the process of sickness when he quit doing it, but he said he couldn't take the sludge anymore.
Yeah.
Yeah, I heard from somebody else too. They mix it with orange juice and it just tastes like really awful. So I don't even want to try it. Just because it sounds gross. Not that I'd want to, but it's just, from what everybody says, it tastes disgusting.
I haven't heard the orange juice, but I can. Yeah, I've heard it. The taste is just awful. So
would it be possible to send me the PowerPoint? Because some people might want a copy of it.
Absolutely. I just got to figure out how to do that. I'm not the greatest with the technology. So.
Yeah, that's awesome PowerPoint. I appreciated that. Thank you very much for all that information today. I learned a lot.
Yeah, a couple of years ago, I went to what was it? Like a 2 or 3 day stimulant summit with methamphetamine stimulant summit, and they were talking about heavy meth use actually causes holes in the brain.
Causes holes, like literal holes?
Holes, yeah, holes in the brain.
I can see that as kind of a figurative, because, you have these huge, I guess, holes of lack of sometimes dopamine or monoamines where you're just kind of, you burnt that part of your brain out for just kind of a lack of.
It's not actual physical holes. It's more of a.
Right. Yeah. Yeah, absolutely. With the lack of dopamine. And again, your brain's just playing catch up after a while, and there's only so much it can kind of keep going up. And then before you know it, it's just kind of burnt out. And it's just a tremendous, uphill battle for patients, because again, there's really no, for 3 or 4 weeks. I mean, for 2 or 3 weeks, you're just they're depressed. So they have no dopamine or serotonin going through their system. They're just tremendously depressed, super fatigued, and all this stuff. And they still have to go through and do life stuff. So imagine that, that trigger, that craving, that reinforcing effect of, oh, if I can just do this, I'll just feel, so much better. So it's so hard.
Right.
When you feel so lousy and people just want to feel normal. So we have to use compassion and patience. And
it's like they sleep for days and then they eat a lot. They'll eat for days after that.
Oh yeah. Yep. Yeah. When I used to work the detox unit in the city, we would, if somebody was coming off a large, cocaine or crack, they would basically sleep for 3 days. And then, after that, it was just pounding food for another 3 days. And it was just, for 6 days, they didn't want to get out of bed. So.
Mm-hmm. Yeah. What were you going to say, Kim?
Complaint that I have with my clients not being able to quit is just because when they do quit, they end up feeling so lousy and they have no energy to do anything. I talked to a girl last week who said even having the energy to respond back to somebody is too much for her some days when she hasn't been using meth. And the only way that she feels that she can feel normal again is to use meth. And that gives her the energy to get up out of her, bed and at least try to go do something.
Right.
It's crazy just that works like that.
The
She
legal
swears-
system,
She
Yeah.
swears it actually helps her live. She doesn't think she'd be able to live without it.
yeah, the legal system expects you to jump through hoops as well, and it can't even function. That's why I think, well, I think this new stabilization program that's going in Grand Traverse County, I'm hoping that might show some hope for people, you know, to somewhere to place them while they're going through that.
Mm-hmm.
Because there's definitely some psychiatric issues.
Yeah, and that's what one of the girls that I was talking to last week said. She's like, we need a place where we can go that's not a rehab, but it's somewhere where we can go and be with people and just, you know, chill for a couple days, you know, just to relax and not be like judged or have to join like a 12-step program and do that whole situation.
Right. So in your experience, Dr. McMorrow, as far as when they go off of the methamphetamines, if they can stay off of it, is there permanent brain damage or does it eventually heal itself?
So, yeah, I think everybody's different. You know, some people will stay on their, you know, psych meds or antipsychotics or whatever. It can be permanent, you know, as far as that. But what I do find is depending on the patient, you know, over time and months, you know, with therapy and the right medications, that brain does start to heal. You know, and people will tell me, I say, you know, this is a long journey, and a year or two later, like, man, I finally feel fun. You know, I mean, well, people are tremendously insulting that brain all the time. So it's going to take a long time to kind of, you know, come back from that. So it's always setting up expectations and supporting. And people will get better and they will heal just like any other organ in the body. I guess it's always dependent on the person, but.
Right. I've heard too, through that stimulant summit that I went to, that there's a higher cases of suicide due to methamphetamine use.
Mm-hmm. Absolutely.
For the severe depression.
Yeah, and it's everywhere. My pain is, you know, I can go out, you know, any gas station, or it's just so saturated, and I'm sure Tim's hearing the same thing. And it's just it's bananas. There's no, I don't know what's going to happen. So this new, it is a methademic now. There is no, I mean, with fentanyl and meth is just, I don't know what we're going to do, but it's scary.
Right. That seems like because there is a psychiatric issue that, you know, as far as the symptoms, there's psychiatric symptoms that come with methamphetamine use. It seems like we would be placing them in facilities rather than having them run around on the streets and taking that chance of something happening to them or somebody else. You know, and I've gone through a lot of personal experience with it with someone that I care about, and the violence is so much worse even now, I think, than earlier. And just the confusion of thinking things that aren't true, or, you know, trying to have a conversation with the person and they're constantly turning it around and thinking that things happened that didn't happen, or, you know.
Yeah, their brain is.
You know what I mean? There's just that paranoia and just getting the story completely turned around and believing it.
Mm-hmm. Yeah, we're definitely lacking in psychiatric and substance use clinics in Michigan, unfortunately. So
yeah, and as Kim said, bugs, they're constantly thinking that like bugs are crawling
mm-hmm.
in their skin, and
mm-hmm. Yeah,
and it doesn't seem right that we just let them, you know, just people out on the streets and not get them the help that they need, because it's, you know, it might be caused by the substances, but there's a psychiatric component to it, and to me, they should be in a psychiatric facility until they're stabilized.
The slide that showed the comparison of pleasure in the brain from sex and methamphetamine, and how significantly higher it is with methamphetamine. does that change over time that they use? I remember reading something that there was some thought that pleasure, you use one time and you're at this level. The next time you do, the pleasure's lower, and then each time you use it, kind of gets a little bit lower, and then even your baseline is lower than it originally was. And does that have an impact on, Suzanne was talking about some of the frustrations that people feel? Is it because they're trying to get back to where they were and they're just not getting there, and it's messing with the mind? And I can imagine how that would play a role in it as well.
Oh yeah, absolutely. I mean, once you get that kind of, insult of huge dopamine, your body or brain naturally kind of decreases, those receptors, and will. So before you know it, now you used to get this euphoric effect for, say, just arbitrarily 2 weeks. Now when you take it, you just feel normal. Now what you do is you go down this slide. So, after a month or two, you're not even feeling euphoric anymore because those receptors have kind of turned off. And now you're just going from barely normal when you take it to constantly being in withdrawal and feeling, just terrible. So you're just taking it now just to feel that normalcy. Whereas before you felt, this huge pleasure rush. So now it's just to kind of keep up and stay out of withdrawals and feeling terrible. Yeah, it's a great point, Tim.
It's definitely a struggle. It seems like, except for the fentanyls and the methamphetamines, it seems like meth has taken over the opioids. So it's like they went from the opioids to methamphetamines, probably because it's cheaper and easier to get a hold of. Is that what it is? Yeah,
and a lot, again, I think about 40% of people have a co-occurring substance use disorder, right? So it's very common to have somebody have an opioid use disorder, stabilize on their buprenorphine, and then develop a methamphetamine use disorder because, that's the addiction, right? That's the disease of addiction. So I know, Mandy, you run an MAT clinic, and you said, and I'm sure you're seeing a lot of that overlap. I'd wonder your thoughts. And again, I never kick people out or take them off their buprenorphine because they're struggling with meth, because, then they're going to be twice as bad if we do that, right? So
it's true. Like we've definitely seen an increase in meth and kratom, cocaine, and I think too, like we hear a lot of comments saying with the opioids, it would give people energy as well, or help with their anxiety. And I wonder if there's a correlation with that, with the meth giving energy, if they're stable buprenorphine and then they're still using meth. So it's interesting if we just kind of keep putting the what's the information that's coming in, especially if there are grants and stuff from the state and they're trying different medications to see what works. Yeah, I don't know, it'd be nice if there could be places or grants to fund places that people can go to for like detox or to kind of get things figured out. I don't know.
Yeah, Kim's right. More providers need to be more understanding because, we personally know someone that was kicked off of her program because she had used meth. That was correct, right, Kim? Yeah. So
the biggest part about that is, yes, her urine screen came back positive for meth, but what they don't understand is that she's been using less and less of it recently. But she sees that as a big win, and we see that as a big win, but her provider, on the other hand, does not, and sees that as a fail, and even mentioned to this person that in the 2 years that she's had her in the program, she hasn't made much change in her situation. So she told me that made her feel horrible, and she doesn't like going to the doctor because she gets shamed, and she's trying her hardest, but she's homeless. And everywhere that she goes to sleep, there's people using meth. So it's hard for her to just stop using. So, her provider's not looking at the whole picture.
And not to mention, she's extremely depressed, and not just from the use of the substances, but because of a lot of things, negative things that have happened in her life.
Yeah, no, I think with that, everybody, I can't speak for the provider, but, I think harm reduction and, everything is kind of making the wave throughout the country. And, we recognize that small gains are a lot more common than these large, huge gains that, we used to recognize, right? So, and these are huge wins. And, somebody who goes from using IV daily to using once a week, smoking to using once a month. I mean, these are huge gains on some of these patients. So, we need to recognize that, and then to destabilize somebody off the medication that they've already stabilized. I mean, think about that. So now you're shaming somebody who is stable on their opioid use disorder. They're working on their frequency and their amount used for their meth. They're coming to the office getting support. They're trying. They have limited, hardly any social support. Just getting in the office or talking to someone can be a gain for somebody, right? So I don't know. It's too bad. It's just really unfortunate. So that's the way I treat them. I think that's the way, hopefully that society will get to. I think it is in a lot of cities, but I think in some areas, and Tim can attest to this, that, we're still trying to provide education and knowledge, which, if enough knowledge, then you can change behavior. And
Just gotta keep trying, keep moving, keep helping people, and hopefully society will get it. What time do we here? Let's see. Well, it's 12:02. So, any last questions or anything? No?
I'd just like to say thank you. It was really, really informative. So I've really appreciated all the information today's presentation.
Welcome. And I'll figure out how to send out this PowerPoint to you guys too.
Okay, appreciate it. I'll share it. So next month, June, Coffee with the Coalition, Linda is going to be talking about human trafficking. So, and those drug trafficking and human trafficking are very often connected. So it's going to be June 28th at 11 o'clock right here. So.
Who's speaking about that again?
Linda.
Oh, cool.
Oh, so, all right. Well, thanks everybody.